like you have articulated. It's one of the critical aspects of HIV prevention. The challenge today, I could say, is about ignorance among the young people. The fact that we have not been able to reach the whole population of the young people in terms of empowering them about condom, the benefits of using condom, and even the process of using the condom. That could be one of them. And lately, then we can talk about commodity shortages that have been experienced as a country. We have all heard about the condom shortages in the country. So yes.
You've talked about processes, people being taught about processes of using these condoms. And there was a time I was at a conference where people with disabilities were being addressed, and they, of course, highlighted that as a challenge for them, that most of them are blind and they're not being taught how to use, of course, condoms. And if you're talking about it, then it seems that it's something that should be done. Then why is it not being done?
So at our level as AHF, I know we have taken this up through the Adolescents and Young People program, whereby in the communities we are advocating. For the general population, yes, I will admit and acknowledge that for the abled differently population, it might be quite a challenge and something that we need to look into and come up with strategies of reaching those specific populations. But for the general population, I am confident to say that we have done much.
You have done
in terms of, yes, in terms of educating and empowering the youth.
All right. There's also a topic of condom fatigue, but we'll be coming back to that later on. Kidogo. Cleopatra, your advocacy focuses on sexual and reproductive health and rights. So how does inadequate, let's talk about now, sex education contribute to poor condom use?
I feel that, well, we cannot say that there is little that has been done, because right now, at least we've made the conversation open, because we know in our African settlements, sex is something that people don't want to discuss. And I feel that is one of the leading factors that it's equally not possible for even young people. Speaking for young people, at least we have services, we have AHF, we have MSTCCs that promote condom use and all that. But previously, we had issues with that discussion. I can openly come here and say that I'm living with HIV. I can come here and tell people that consistent and correct use of condoms will give you 99, not even almost 100% prevention from HIV, from STDs, and of course from unwanted pregnancies. But I feel we still have a lot to do, because the information is out there, but most of the time the information is not correct. You'll find people will say that the condoms that are available do not fit. Some will say that they are allergic and all that. But you see, those are just things that we young people want to escape from using condoms. But a lot has been done with regards to that. And I feel dissemination of this information and sensitizing young people of the importance of using a condom is very important. And what AHF and STCC is doing is a very good job, because apparently you realize that people are taking this information as a preventive measure. We have other preventive measures. There's PrEP, there's PEP. But remember, those measures, those preventive measures do not prevent you. They just prevent you from HIV. They don't prevent you from STDs. They don't prevent you from unwanted pregnancies. And you realize those are the leading triple threat that we have in this country. So as a young person and a person who is living positively, I feel that everyone, it's not our duty, it's not Daktari's duty, it's not Madam Naomi's duty, but it's upon our duty to continue with this conversation. Because as much as we want to feel that it's not upright as with the African setting, it's a conversation we need to embrace, having in mind that we're still having new infections when we have ARVs that are suppressing, when we have condoms that are supposed, and all those preventive measures, but we still have new infections.
All right. The issue of PrEP, Daktari, of course, Cleopatra has talked about it. Would you say that now, with PrEP being here, it's now making people more reluctant and ignorant towards using condoms, whereby they say that, oh, PrEP will just prevent me from getting HIV?
But that's one way of looking at it, but you have to look at the whole prevention toolkit. And we began with the condom, which, if you ask me, is the most effective prevention outside of abstinence first, and then the whole condom. Because you get prevention from HIV, STIs, and the unwanted pregnancies. So PrEP is just another tool to prevent HIV, but PrEP does not prevent pregnancy or STIs. And so we have seen, especially in young people, with the introduction of the newer prevention technologies, a fatigue for using the older ones. But even when you talk about PrEP, which is absolutely effective, they still also lack of knowledge on how to use PrEP. Some people don't even know what PrEP is.
Yes.
So we get a lot of young people misusing PrEP. You take for 2 days and then you stop. You do event-driven PrEP and then you stop. So I think for us as a government agency, when you look at prevention, what we advocate for is teaching about the whole prevention toolkit. And we always start from abstinence. We don't jump to a condom. Because abstinence is 100% effective for everything. You be faithful, use a condom, know your status. If you cannot, then you use PrEP. So we give you options. I mean, humanity is about being given options and making a choice. So you make the choice that actually works for you. I also want to comment about something that you asked about earlier, sex education.
Yes,
you
please.
must distinguish between sex education and sexuality education. Sex is the act. And so when we are promoting condoms, we are not advocating that people actually go and have sex. But we understand that those in situations where that is the only option. And so as we teach young people starting from children, we must talk about human sexuality, which is how do you embrace your body, menstrual hygiene, menstrual process. How even we're seated here in this stage, we're basically expressing our sexuality. So a lot of the should I say, clapback we have gotten from the society that when you mention a condom, they're saying you want the children to have sex. We don't want that. We're actually advocating for abstinence, isn't it? Yeah. But condoms is just one of the prevention commodities, the tool that is available there. So we have to do the whole package, not just one intervention.
And when I love that you've also highlighted that we are not talking about sex education, but sexuality. And many African societies define sexuality in binary terms, male and female. So when we're looking at it at this perspective, given what we know about human sexuality, isn't this framing limiting to just heterosexuality?
Human sexuality, and I see where you're going. I see where you're going, so let me try and answer it in the smartest way. Everybody expresses their sexuality as they were given by God. You understand? Whether you choose to see it as male or female or whatever it is, but everybody expresses a sexuality. If you look at traditional African culture, we were taught about our sexuality. It still happens in our communities now, where the girls will sit with the aunties, grandmothers, and the boys with the grandfathers and the uncles, and it's not about the sexuality. It's not about the act of sex. It's about how do you engage with your colleagues? How do you engage with the opposite sex? How do you express yourself from your dressing, from how you do your hair, how you do your makeup, for example, in the modern context? That is sexuality education, isn't it? Even how you want to be perceived as you communicate, how you want to, even a handshake also is how you express your sexuality. So we look at it in that scope, not in terms of gender diversity. You understand? So however it is you're taught, the teaching is that be safe, all right? Make a choice that works for you. And choice can only work for you if you make it from an informed perspective. So we're all about giving information.
All right. I want us still hapo. Dr. When NSDCC rebranded from NAC, that is the National AIDS Control Council, right? How does it now change your mandate? Because initially, NAC was majorly on managing HIV.
Yes.
So from NAC to NSDCC, how does it generally now change your mandate?
Okay. So I'll talk about the word syndemic, because I think syndemic is one that confuses almost everybody. So syndemics are just overlapping situations or diseases that basically confound the HIV epidemic. You can talk about mental health, gender-based violence, also TB, because a lot of patients who are living with HIV also have got TB, isn't it? If you go to some areas in this country, you will have HIV, TB, and malaria. This is the same individual. And so when you think about it from a cost-effectiveness perspective, when you think about it from a human-centered design, the segregation of treating the disease versus the person is what we are trying to move from, okay? So syndemics encompasses all that, including also sexually transmitted infections, which, by the way, are on the increase in this country. That is troubling. But all those ones also influence what happens in the HIV epidemic. So our mandate is expanded to include all those other diseases and anything else which may come up. But for us, we are still doing policy, we're still doing guidelines, we're still doing resource mobilization, we're still supporting the counties, and we're still looking at the data and churning it out in a way that those who need it can use it as quickly as possible to make decisions for our citizens.
Amazing. Naomi, there was a time AHF was really criticizing the government for failing to prioritize condoms in national health strategies. Was that addressed?
It was addressed. It's a conversation that is ongoing. And in terms of AHF is in the front line of condoms. There is at some point we were procuring some condoms as a program, but I think that is something that has been addressed, and we are in the process of, we are in the condom program discussions together with NSDCC and the other programs. To ensure that that is prioritized. Yes.
So what are the gaps right now in Kenyans' goals towards just making condoms accessible and properly used?
So the gaps right now are in terms of, and Dr. you can help me with this as well.
Please.
Yeah.
Yeah. So I think the number one is, I think, lack of information on the condom, on the use of the condom, isn't it? Yeah. Like I told you, it's the most effective prevention tool outside of abstinence. Yeah. So there's a lot of ignorance, and there's a lot of myths and misconceptions. We were discussing earlier about men saying that the condom does not fit them. They fit all sizes, all shapes. Yeah? Let me just put it like that, because we're on
size issue.
We're on national television. Yeah. And of course, the condoms come, KEBS pre-qualified, and WHO pre-qualified, so they're of good quality. So there's that misinformation. Another thing I think is the issue of access to condoms. And we've done a lot of work with our partners, AHF, UNFP and other partners, and even the communities, with ensuring that we actually have got condom distribution points. And so for us, when we're thinking through it, we asked ourselves, where is sexual activity most likely to happen? It doesn't happen in the health facility. It happens in the bars, the lodgings, the restaurants, all those areas. So we did a condom mapping in the whole country. We installed dispensers. And to our surprise, the uptake of condoms was actually astronomical. There was a time actually I think we were struggling with refilling the condom dispensers. And so the desire to use condoms is there. The desire even to buy condoms. If you look at our condom market, 98% is, actually not 98, 84% is free to use, like free government condoms. But 70% of Kenyans are saying they would actually buy a condom if there was no free ones. And so for us, we're trying to engage the private sector, because we want a total market approach where you have government, you have got the commercial sector, private sector. Let everybody come. If you can buy a bottle of beer, surely you can buy a condom, for as long as you know where to get it, isn't it? So you must also think about what we call product placement. Where do you use the condom? Because of course you won't go to your supermarket and put the condom next to, at the till. People actually get very shy to pick it from there. So also product placement is important, So it's about access, and then also occasionally we don't have enough of them, and that's why we want the private sector to come on board, so that we actually flood the country with condoms, because it's actually a very big need and a big desire, as we also do condom advocacy and condom education.
You see, there was a time, sometime last year, when we did a story about condoms being very, very few in the country. Does it actually get to that point where now condoms are not there? If you are distributing them, but people are still buying, yet there are no condoms as per those reports, then does it really get to that point where now hakuna condoms?
I think let's and I'm going to ask you which condoms were not there. I'll ask you which ones were not there.
The ones that are being distributed.
Exactly, and that's what I'm saying. We want to move away from the free condoms, isn't it? There are those people who genuinely cannot afford because of their social economic status, and those condoms should be there for them. But the vast majority, even young people, and I always challenge them. I was at university 2 years ago, and I told them, if you can buy a drink, a shot of gin, honestly, you can buy a condom. Can you not? Isn't it? So for us, we want that if you need a condom when you need it, you can actually get it. So when we talk about shortage of condoms, you have to look at the whole market, including even the commercial ones. And then maybe let's begin discussing pricing of the condoms. So can our populations afford? That's the same way you would have, for example, bath soap for different social strata. Can you also then have condoms so that you pick what you can afford, as long as it's a quality condom?
I love that we're having that conversation about now moving towards selling condoms, buying them now. Because you see, we've had this conversation, and I know I'm trying to deviate a little bit, that if we are selling sanitary towels, if this is something that is nature, but we are giving condoms for free. Maybe do you see us getting to a point where now one day pads will be free, because now we cannot change it, you know, you cannot change this call of nature. Yes. Clear.
I feel that that is a point that should have a lot of discussion and a lot of concern to us, and I'm happy because the two sides contribute to distribution of sanitary towels. As a person, I always go for sanitary towels from AHF, from NSDCC, but I feel if we can make
just hold on
that we are giving free.
I think somebody might be hearing this, Nana Shanga. Sanitary towels from NSDCC?
Yes.
Let me qualify that.
Yes.
Ooh.
So, you know, you've heard of the triple threat campaign.
Yeah.
So where we have a reduction of teenage pregnancies, HIV infections, and gender-based violence. So as part of our campaign, when we go out to the community, one of the things that we do distribute is sanitary towels, all right? And as we give information. Now, I will say free is relative. Free for you, but somebody has bought it. And so for us, what we have done, because part of our work is to work with different sectors to put into the HIV response. So we're getting a lot of support from the private sector, from private individuals, private entities, to make that sanitary towel free for the very, very poor girls who cannot get it. So that is why you'd actually come and say, I have a CBO here, maybe can I get? It's not that we have a limitless stock out, lest we get flooded tomorrow in the morning, but that is how we have been doing. So it's been part of our collaborative efforts with our different stakeholders and entities. In the ideal world, it would be perfect if those free sanitary towels for each and every girl who needs it. Because some can actually afford to buy. But it's a bigger discussion than with the NSCC. It's the MOH, it's the Ministry of Finance, Treasury. How do we actually finance these essential commodities? Yes.
What is the most common misunderstanding young people have about their reproductive health when you're interacting with them, Cleopatra? Now that you are an advocate for HIV and sexual reproductive health rights, I want to believe that you interact with a lot of young people, of course, trying to create awareness on HIV and sexual reproductive health. So where is the disconnect when they're trying to really understand more about their reproductive health?
The disconnect, the first and foremost, is the access to youth-friendly facilities. We used to have, what I want, when we're having this conversation, I want to put it that we are not where we were before. There is a lot of changes that have been made right now with regards actually to youth-friendly services. We have very friendly services because wengine, most of them wanaogopa. If I go to a facility and then I'll get someone who is the age of my mom, I will not tell them that they want, I want to have family planning, I want to access some condoms and all that. But apparently, right now you can walk to any facility and you'll get family planning, you'll get all SRHR services at your disposal. But this information is not out there. Young people assume that once you go to a facility, hauwezi pata hizo services. So wana feel heri ninyamaze. If you have an STI, you're afraid to go to the hospital, you're afraid to go and get diagnosed, you're afraid to, because they believe that people will judge you and all that. But we want to pass the information. And the reason we are doing this advocacy is we want people to know that you will get help. If you have an STI, you can go to facilities that offer that and you'll get help. But now, at the community level, let's say, sasa watu wa Nairobi, at least hao tunajua mambo, unajua unaweza enda HF, unaweza kimbia hapa, but at the community level, this information is not there. So the backbone of all this is that we need to disseminate the correct information. The information is there. It's the same way that we usually say that people know that HIV is there, but the thing that people know is that HIV is a killer disease, and apparently young people, again, the information iko kuna dawa si ni moja tu. When they see me advocating that you need to adhere, wananiambia Cleo, si dawa iko moja tu, but they don't understand that lifelong treatment is not an easy thing. We've been there for a long time and we know it's not easy to adhere, to go to your clinics, but the assumption is young people are actually afraid of getting pregnant.
And I was coming to that question.
Yes, that is what
you hear more. Is it pregnancy or HIV? Heri nipate mimba. What do you hear more?
Sasa wanaogopa mimba. Yes, that is the current situation that we are. Because wanasema HIV si nitapewa dawa na dawa ni moja na ni free. Kwanza wanasema ni free. Ni free iko. So they feel it's okay. And when I'm talking about this, that's why the Daktari has said about the preventive measures. We want to advocate for a preventive measure that will stop all those the triple threat that we have, because these are the contributors of the highest infections that we have in this country are from young people, adolescents and young people. That is the age between 14 to 24. And my question is always, if we have drugs that are suppressing the virus, that you can become undetectable if you will not infect someone, we have condoms that are being distributed. Why is it that every other day we are getting new infections? That means people know the information is there, but they're ignorant. They don't want to take their steps. People don't want to get tested. And I'm very happy with the fact that right now everyone is campaigning for testing. We have self-testing, we have access. You can access self-testing kits that are free, but people do not. Even the new infections are not coming from us who know our status. Mimi mwenye najijua na meza dawa niko undetectable, I cannot infect. But these new infections are coming from people who do not know their status. So this conversation goes down to people getting tested. That is the first thing. Knowing your status is taking responsibility of your life. Once you get tested, that is where you know. And I usually say testing does not it's not a mean that we are pushing you, we are coercing you to do that. But whether the results are positive or negative, if they're positive, you have another way. You'll get your drugs, you'll start on medication, you'll adhere, you'll get to UST. If the results are negative, you have another chance to continue with the preventive measures, putting the preventive measures so that you maintain the same status.
All right. Naomi, I want to come back to you now. You see, at the AIDS Healthcare Foundation Kenya, that is AHF. I'm avoiding saying AHF. Ama watu wa Kisumu wanikujie, nimeze. You know, you distribute millions of condoms yearly, but do you track whether these condoms are being distributed to the places that they need to, or they just get discarded? Do you track?
Yes, we have a way of monitoring and tracking. The distribution points are in the health facilities, and maybe this is an opportunity to highlight AHF as a program. We have 2 standalone facilities here in Nairobi. One is in Parklands, the other one is in Mathare. And just to go back to what Cleopatra was saying, we are working with a specific adolescents and young program, Safe Spaces, whereby we are able to offer comprehensive services to the young people. And in terms of tracking, we are using the community power voices, the community health promoters, as well as the youth champions. Those are the peers in terms of distribution and tracking to ensure that they are in the right place where they are needed, like we said, the lodgings, and they're with the right people, yes.
You know, there are reports that young people fear carrying around condoms, and at Cleopatra, you people have talked about it, that stigma, right? So how do we normalize condom use beyond just availability, Naomi?
So for condom use, we are doing a lot of education, prevention education as an option of prevention. So we are able to discuss about condom to just try address the stigma and the shame associated with carrying a condom or using a condom. So a lot of condom education, empowering the population so that they are able to handle it confidently. Yes.
All right, Daktari, you know, Kenya still experience high STI infection rates despite these health campaigns that are available. So what would you say is the most overlooked factor when we're talking about STI prevention?
I would say information. A lot of the focus has been around HIV. And not so much talk around gonorrhea, chlamydia, and the other ones. And so they have sort of crept up on us. But if you look at the transmission dynamics, if you have an STI, the risk of you getting HIV is higher, and of course, vice versa. And so that's why also, again, the word syndemic. How do we now start doing the human-centered design approach and talking to Cleopatra as a person, not looking at what she may or may not have as a disease and splitting them. So comprehensively talking about sexually transmitted infections, and HIV being one of them. So a lot of information needs to be given. Data, we're now starting to look at it more keenly because of the intersections that we're seeing. Anyway, of course, you're seeing high STIs, you're seeing high HIV infections, and also high pregnancy rates. And so that also is our work as the NSCCC. So how do we look at different data sets from different health programs that actually tell the story? I wanted to talk about what Naomi was saying, the distribution of condoms. You know, distribution is not equals to use. I can distribute to you 10, but you don't even use a single one. And part of the limitations we have been having is that it's very difficult to measure use unless I come and ask you, did you use a condom? And so we do that through surveys, the Kenya Demographic Health Survey, which we do every 10 years. So you can distribute for 10 years, but you only get to know about actual use when you ask an individual every 10 years. And so that is why we normally rely on the data. So every year we have estimates. What are the new HIV infections looking like? They are on the downward trend, I'll have to say. Right now, adolescents and young people 15 to 24 are contributing 39% from a high of it was over 50% in around 2015. But if you extend that age band to 34, it is actually 72% of all our infections. And so for us also as a government agency, we're now looking at the age band up to 34 because they are still considered young people in this country. And if you look at the sexual dynamics, you find a 21-year-old girl with a 32-year-old man and vice versa. So you can't focus on this narrow age band neglecting those ones because there's the whole transmission which is occurring across the different age bands. So when we extend the age bands, it is alarming. But within the age band of 15 to 24, they are coming down. Generally, in Kenya, infections are coming down, but not quick enough, because we want to be at less than 1,000 new infections by 2030, which is like 5 years, and we're at 16,000 right now. So a lot of work has to be done. So it is government responsibility, partners, societies, but also personal responsibility. How do we all work together and ensure that everybody is safe, healthy, can access what they need to access when they need it?
Now, that also... I think it also answers the question that now that I'm 21-year-old girls with almost 35-year-old men, that sana sana HIV inasambazwa na wababas. You know, I'm saying this because this was something that was revealed by someone from NASCOP last year, and I did a story on that. And he was talking about now HIV being more prevalent because now there's the relationship between wababas. And I also went to the streets, and you know, the young girls were saying, Nani anambaba sai? You know. So Cleopatra, would you say that young girls have normalized these older, intergenerational, let me call it that, sexual activities that are now promoting AIDS or HIV?
Yes, they have. And I feel it's something that has come from how we are right now in the community and the society right now. People are so concerned. Young people are so concerned about what is happening, the trends and all that. And you find a 21-year-old will not afford an iPhone in any way. I don't think even a parent will. We have some who will get you, but they want to keep up with the standard. They want to keep up. And for you to keep up with that, you'll have to go for someone who has money. That money, you won't get it from another 21-year-old. And that is why we are having those instances where we have young girls with older men. We have not even girls only, even boys. Sahi hata vijana wanawekwa, si wasichana peke yao. And you find even young boys are saying, that is what I want. Mimi sitaki kuhustle. And then you understand the rate at which there is a lot of, the rate of poverty in the community. It's equally very high, and you'll find these girls cannot even access. You cannot, like Dr. said, not so many can access even some of the necessities that you need. Unahitaji sanitary towels, unahitaji mafuta. Akienda huko nje apatane na mtu mwenye atambaia, atakubali. And what is the end of that? No one will give you things for free. Of course they won't. And these people, the fact that you're young, you cannot even advocate for condom use. They won't even, some of them don't even ask for consent. And you realize consent is one of the factors that needs to be considered. If I'm not, a no is a no. But some of these things, when it comes to the fact that we were saying about sexuality and that sex education, people don't know that. Haujui unafaa ukiambia mtu, some men don't know when you say no, it's no. And that is where we get SGBV, we are getting a lot of violence in these relationships. And the bottom line that I said, and that Sharia said, and Naomi says, that it's information. We need to pass this info. The information is there, but we don't have the correct information. So you need to tell a young person that you cannot wake up today and become rich today. You cannot wake up. You need to work yourself up there. But now tunataka kuharakisha maisha. Tunasema, na mimi huambia watu nasema, kuamuka ina deadline. Just go with your pace. You'll get there. You don't need a mbaba to get there because you're exposing yourself to so many things. And that's why we'll keep having these new infections. Because ukipata huyo mtu, there's no point nitaenda ni advocate for a condom. Kama hataki kutumia utamwambia nini na anakupea pesa.
Ashakupatia pesa.
Ashakupatia pesa. Uta have kulipia hiyo pesa.
Alright.
So that is what is happening.
Naomi, you see, adolescents are sexually active, and there's this conversation revolving around them getting limited access to condoms or them not getting access to condoms at all. And so my question is, should age restriction of condom distribution be scrapped off?
So age restriction. When you're talking about adolescents and young people,
the
age band we work with is 10 to 24 years.
Oh, okay.
Yeah, so, but when we talk about sexuality again, it has to be age appropriate.
Okay.
Because the information that you disseminate to a 10-year-old might be different to the information you disseminate to an 18-year-old who is also a youth.
Okay.
So I can't really talk about scrapping off. It's just customizing it to be age appropriate. Yes.
Why do you think sexuality is still a taboo topic? And you're smiling, Cleo. You wanted
that's why you wanted to say something.
Okay,
I want
yes,
to talk
please.
about, so you've talked about scrapping the age restriction for condom distribution. I'm not aware that we have one. But of course, we will not give a 10, 11-year-old a condom. That we cannot do, we don't advocate for.
And you know, we have, I will not say teenage pregnancies, but we have such as low as 9.
We have little girls, but by the law, what is that? It is gender-based violence.
It is.
So we're not going to promote gender-based violence by giving the 10-year-old a condom, isn't it? This girl most likely did not give consent. Somebody took advantage of her. And that is what we are trying to educate the community, that a 14-year-old girl pregnant is not normal. That's not normal. And I think as Kenya, we have become so desensitized. We're so desensitized, isn't it? We talk about it when they're about to do end-of-year exams, and then we keep quiet and we wake up in November. Media included, I'm also challenging the media. So teenage girls who are pregnant is not normal anywhere in the world. And so we don't normalize by giving condoms. Those are girls who basically need protection, isn't it? A lot of them are desperate. So they will actually have sex for school fees. They'll have sex for a sanitary pack of sanitary towels, isn't it? So you have to contextualize the discussions. So age appropriate information, isn't it?
Please.
So you will not find as government we are dishing out condoms to 10, 11 years. Those are children who basically liaise with social protection for rescuing of those children, both boys and girls, isn't it? It's different if you take condoms to a university. They're above 18, they can give consent. But then even as we talk about people being sexually active, not all are. And we always forget those ones who have chosen not to do it. So also those ones we applaud and we say, keep on doing it, keep abstaining until the appropriate time. So it's that's why I'm saying the human-centered design is really important. The person-centered approach is not blanket for everybody.
So should consent education start in primary school now that we're talking about consent? Sometimes these adolescents don't even know what consent is. They're not giving consent to this person who is gender-based violence is conducting these activities on them.
Starts in the house, not in school. School is
It starts at home.
So when you tell your 2-3-year-old, these are my body parts, that is sexuality education. That nobody can touch you. The 3-year-old knows no one's supposed to touch me. Because boy and girl, that is sexuality education. So we can't leave it to the school. There's the part for the school, but the teaching starts at home, at the parental level, household, but also at the community level. I understand also home dynamics have really changed over the last couple of years, but what is the community around the child? So also for us, we empower the community around the child.
All right. So now in societies rather where men are expected to be dominant in relationships. Now, how does this affect young men's understanding of consent and respect? Cleo?
Most of the time, you've said in societies, because we have them, that we have communities that women are, there's a lot of masculinity and women, their opinion are not considered. But what we can do is that the information needs to be taken. We are not hizo enzi zenye tulikuwa tunaishi that a woman cannot say no, a woman cannot say, because most men, they usually say that a no is a yes. That for women, ukisema hapana, even for young people, and I think that is the reason most young people, you'll find so many cases of SGBV, because atasema, mi alisema no, nikasema ni it's a yes. So I think we need to disseminate that information, and times have changed. And we cannot ignore the fact that times have changed. We cannot be dwelling on the past, and people have been empowered. And to be precise, women have been empowered. So it's upon us to give this information that even those women should fight for their space. You should fight for your space. You should fight. You should know what is needed from you. And well, many men will feel that is disrespect. I agree. But again, tunafaa tu tukue empowered. We should just empower them. I feel it's all about the empowerment because, but then again, utaona, if they feel that is disrespect, that is where GBV comes in. And you'll find, ukisema hivyo mwanaume atakuwa anampiga and all that. But the information needs to be passed. And I feel even men, they're not hard people. I've seen men, when you talk to them, once they understand where you're coming from and all that, you get to be on the same page.
Okay.
Yes.
So.
Maybe to add on that.
Okay. Let's start with Naomi and then you can add.
Okay. So on the same, AHF as a program, you know, initially we used to separate the boys and the girls when we were giving this sexuality education until we realized that the misconceptions were coming up. So what we are doing now is to have integrated sessions where we are able to bring the girl and the boy together and have this conversation. Part of it is to build the skills for the young people in terms of the negotiation skills, the assertiveness, the communication skills. How are you able to give consent? How you're able to say no? How you're able to negotiate for safe sex and respect as well for your partner. Yes.
All right, Dr.
So at the national level, last year, because we started looking at the data a couple of years back, and the data for boys actually is alarming. So more women get HIV infection, but more men are dying of AIDS-related issues. When you test, out of 10 men who you test, 7 are going between the ages of 15 to 34. So that's a lot of, that's 70% of our young men are working, our productive age. And so we launched the framework for engaging men and boys in the HIV response, because for us, we are categorical. Men are allies. We're categorical. Men are allies. They are not the enemy. And so there's different thematic areas in that framework. And I think AHF, you're embedded in it, isn't it? About changing the narrative around what is masculinity. So we work with community gatekeepers. So men talking to fellow men, we don't do it. Because as a woman, there's nothing to understand about being a man. So engaging the men to engage fellow men, community gatekeepers, men from all the stratas of society. How do we have integrated programs for both young men and young women, so that we remove that division? Because it has been there for a while. A lot of emphasis on programs for girls and not so much for boys. But even at the global level, in terms of prevention, men and boys are now recognized as a prevention pillar. So I think everybody is aligning like that.
So why is sexuality still a topic that is considered a taboo in conversations at the community level? Many societies. No.
Okay, so for me, I think it goes back to the socialization. We are an African society, an African culture. And even if you look at Kenya as a country with the different cultural backgrounds. So I think it has something to do with the culture, how we were made to look at sexuality. It is something that, especially as the older generations, the millennials and the former generations, we were not able to discuss it freely with our parents. But as it is right now, and as you can see the Gen Zs coming up, we are able to discuss it freely with them. The information is out there. So for me, it goes back to the socialization and the culture aspect. Yes.
Claire?
I feel apparently it's very easy for me to have a discussion with my small sister about the body changes and all that. But I feel previously, even our parents, there is no one that sat me down and told me that this is supposed to happen, this is going to happen. And there's a change right now. Again, remember that young people have access to social media right now. Even in schools, the curriculum has really changed, because when it comes to the education, these are things that were supposed, they are discussed under the carpet. And I will mention even about HIV. These are discussions that people are not comfortable having them, but apparently a parent will sit with a kid and tell them that, you know, this is happening, you're supposed to take care of yourself. We have such a program that is happening, that we are trying to talk to people. And I think information is everything that we have lies on communication and information. Once we get the right information, everything will align. Once we learn, because learning in school is not enough. And I agree what Dr. is saying, that some of these things, some parents have left them to the teachers, and you realize there is a disconnect between parents and kids. And I feel as a parent, you're supposed to start this information as the kid goes, that they know. Even when they'll get out there, they will have a reason. If a kid is raped, if someone does inappropriate things to them, they'll feel comfortable to come and talk to you. Because you find that there are kids who are taken advantage of. Kitambo na hakuisema, but they are living with that bad then they didn't say, and you find such occurrences have so many risks. That kid can get HIV, they can get STDs, but if they are not in a point that they can have this discussion with their parent, or they are not confident that they can share it with another person, then huyo mtoto ataishi kuwa tuna hizo. And that's why we have so many people living with traumas, because they did not get to know that if I have a problem, I can confidently go and tell Daktari and she'll help me out. And again, young people we are afraid of being judged. No one will come out. If I have an STD, I'm not comfortable even walking to a facility because you will assume. And I tell young people, hata ukienda kwa huyo daktari, hakujui mtapatana na yeye wapi. You need the help. So it's upon you to be confident and access these services because they're there. And we need to stop even the perception that nobody can take care, that we don't have the youth-friendly facilities, they're there. And the last one is that information is there, but we need to give the right information. You realize that hizo enzi za kitambo that I'm saying, we had HIV information, but we used to learn that HIV is a killer disease, it's sexually transmitted, we have so many ways of transmission. So we need to at least go with the flow. Na naambianga watu, science continues to advance. Tusibaki tuko kwa stigma kwenye you cannot shake hands, you cannot invite me here, tukipatana daktari hata wataki wewe utaki kunisalimia. Things have changed and science continues to advance every other day. And the best that we can do is that pia sisi tuna grow na technology. Amesema juu ya Gen Zs. People didn't know that I equally did. I'm not a Gen Z, but people didn't know that Gen Zs can do whatever they have done. But now the fact that we are evolving and the world is continuing to advance, we should put up to that. And that's why we can openly have this discussion. And we want to tell even parents at the parental level, you need to tell this child, venye tu wanaambiwa tu, these are my private parts, wakiendelea tu hivyo. And the same way when it comes to disclosure about HIV, we have kids who are born positive. And you find kids, parents will keep lying to them. Anamwambia dawa ni za kifua, ni za kifua, ni za kifua. Personally, I was disclosed that at 13 years. Na mimi disclosure yangu ilifanywa nikaambiwa it's HIV, unafaa kumeza dawa and all that. But, so it has been very easy for me to accept. And well, it's not like it has been a very easy journey, but right now naweza sema nimejikubali, and I feel that even though the stigma is there, I'm living publicly, I'll get very negative comments if you check my TikTok, my social media. But then I say, you cannot use what I've accepted about myself against me. You cannot use that. And that is one thing that is leading to the many adherence cases that we have, because hatujaanza mapema. And it goes down to what you've said about early disclosure. Sio lazima umwambie ni za nini. There's a process, pole pole tu. By the time mtoto anaenda hataona dawa kwa TV kama sasa dawa zinashinda. Hakuna news zinasoma dawa haziekwi. So this child umeishi kumwambia dawa ni za homa, ni za pneumonia, ataona hapo. That is unwanted disclosure. Na huyo mtoto atadecide tu hatameza. And that is why we'll continue having new infections among young people. Kwa sababu akidecide hivyo, atakuwa anaenda, hata mimi I was there, nilikuwa naenda hospitali nachukua dawa. Lakini hawajui simezi. Nitakuja na nitazitupa. That is what they'll do. But if we continue doing this and passing the information at an early age, we will stop all this. Hizi vices zote, hizi triple threats zote zenye ziko. The same way she has said, if we continue from hapo chini, kuongelesha mtoto as a man to tell them you're not supposed to hit a woman, those GBV cases hazitakuwa.
Anajua akiwa mdogo. Daktari, you see research sometimes says that married couples usually don't use condoms, or they use it less, yet they're not immune to STIs. So how do we address this in public messaging to also, because sometimes you see somebody is asking which condom is the best, and somebody would ask them, why are you using condoms and yet you're married? So how can we now address this in a manner that now tells them that it's okay to still use it in as much as you're married?
There would have to be, I understand the dynamics of marriage, and I've had those questions, but she's my wife, he's my husband, why are we using a condom? But if you choose the condom as your preferred family choice option, that is okay. Family planning choice option, that's fine. Just the same way a woman could be on the pill, could be on the coil and what have you, isn't it? But the one thing that we advocate for married couples is be faithful to your partner. Know your status and know your partner's status. Remember I talked about the ABCD. Abstain, be faithful, use a condom, disclosure, like what she's talking about. So you just can't pick a condom and say condom married people. There's the whole spectrum of the prevention toolkit. So we give information. So for some couples, the option is not to use a condom because they know each other and they know their HIV status, isn't it? Yeah. For some couples, they decide to use PrEP, isn't it? Because, I mean, I'm discordant, I'm positive, my partner is negative, so we use PrEP as our preferred method of preventing HIV, isn't it? For some other people, they'll use PrEP because they don't trust their partner. They're constantly at risk, so they'll actually come for PrEP. So options are there. But I think, and I think it just sums up what my two co-guests were saying, is about honesty. Just speak the truth. And understand yourself and understand your situation, because whatever situation you're in, there is help available. And part of our advocacy is saying you don't have to struggle alone. There's actually help available for you. So what do you need? This is the array of tools, interventions, which one works for you. And they may work at different times. January might be the condom, February is PrEP. But for as long as you're protected, I think that should be the sound base of all of it.
Amazing. Female condoms are rarely discussed. So why is there a low uptake of female condoms? First of all, do you know the people who don't know that female condoms exist? Naomi?
Yes. And I think I would associate that to, first of all, the fact that people don't know that they exist. Yes. And mostly the uptake is in the female sex workers mostly, and also the dynamics of using the female condom, because like the female condom has to be inserted way before the act.
Is it 2 weeks?
No, like
you see?
Oh my goodness.
Yeah, like a few minutes before the yes, and then again the perception of the male partner. They influence that most of them are not comfortable with using the female condom. So I think that contributes to the low uptake. But then again, we are still giving information about the female condom. More information, demonstrations on how to use it, and that might just improve the uptake.
And they're also expensive, So it's more expensive than the male condom. So it's cheaper to buy the male condom than to buy the female. So they're there, I mean, but not as many as we would wish, also because of the cost. It's a very expensive condom. So a lot of advocacy you find leaning towards the male condom, but like Naomi has rightly said, the female sex workers, I mean, for them, the female condom is the preferred condom of choice, because that also empowers them. Actually empowers the woman. And that, so they are expensive.
Why is it expensive though?
Well, I don't know if it's a discussion we can answer right now. That would be at manufacturing level, isn't it? Yeah.
All right. Cleo, do you think that we should invest more in now promoting female condoms, if we're talking about it?
Yes, we should. But again, I don't think, I don't want to be misquoted, but like she has said, there are so many dynamics when it comes to the female condoms. We have had, you've been distributing, AHF has been distributing some female condoms. I've equally gotten some, and I took them to the community. Our organization is based in Kidorai, and you'll find not so many people are ready to use it. So I feel, again, we don't want to put so much emphasis and invest in so much that is not effective. Remember, we are doing this because we want to deliver efficiently and effectively. If at all it's not working and people are not comfortable with, why don't we then concentrate on what is doable and what is working? So it's equally good to pass the information, because anyone who feels that they're comfortable, they can access it. And I'll go back to what Dr. Aria said. We need to make these commodities affordable for everyone. So that if we have a point where a person feels that they want to use the female condom, it's easy for them to access and afford. Yes.
All right. There's feedback here, and I guess this one goes to Daktari. Blessed Alan Pro from Likuyani. He says, show is lit. But one problem, we have issues with condoms in our community. No condoms, more worries.
No condoms. Which condoms again? Which condoms are not there? And I know what he's referring to. He's probably talking about the free public condoms. And that is part of the let me call it a myth, for lack of a better word, that we need to debunk. So just because you cannot access the free government condom doesn't mean that you cannot access another condom. There's condoms in the market, the commercial ones, isn't it? There's the ones from the private sector which you buy. So it is about individuals thinking about what do they want to invest in themselves. If I can't get this one and I can afford to buy, I will buy it. I think also one other problem that we have made with the condom is that we have made the condom a medical, it's actually classified as a medical device.
Yeah.
The condom is a medical device. And that's part of the work that we're doing at national level. Because if you look at something like toothpaste, toothpaste, who's the biggest beneficiary of toothpaste? It is the dentists. But have you ever seen the Ministry of Health removing an advert for toothpaste for Colgate? Isn't it? It's not, but it's about oral health, isn't it? And the condom needs to move from being looked at as a medical device to now something which is social, like another commodity. You understand? And we even had discussions in our working groups at national level. Let's promote the condom and make it around pleasure, not always about you're preventing HIV, STI, pregnancy. Because that narrative also puts people off. So how about promoting the condom for pleasure? And if you look at the private sector, a lot of them actually do promote the condom around that. So what I would tell the gentleman who asked, so the free one is not there, but what else is around you? What else can you access just around you? So let's look at it like that, yeah?
All right, there's a question here. What role does gender identity and sexual orientation play in conversations about sexuality? Cleo?
Okay. I think gender role.
Yes.
I don't want to, I really don't want, like the
we give that
to escape.
Because alikuwa ameanza to say something about sexuality, so that you can just now.
So I will, if you look at the umbrella of sexuality, gender identity and sexual orientation is just one aspect of your human sexuality. Okay? So it's, if you go read about it, it's just an aspect, isn't it? Yeah. And sexuality, of course, is determined by your core values, your norms, all those things that you see in the household, the community, in the school, isn't it? Yeah. So when you talk about orientation, and I'm very careful how I'm putting, it's just an aspect of human sexuality. Regardless, for us, our promotion is wellness. Are you safe where you are? Do you need what you need when you need it? That is the conversation. So the rest of it becomes almost immaterial. But if you look at the HIV dynamics now in what we call the key populations, because it has come up, the men who have sex with men, including the male sex workers, the female sex workers, and the injecting drug users and the transgenders, we see higher incidences of HIV, okay? We see higher prevalence. Prevalence is just the number of that community who are living with HIV. And so also then work goes around advocacy, ensuring they have good services when they do need them. But for us, regardless of wherever you lay, you determine that you fall. For us, it is public health good. So what if you need a condom, can you access a condom? Even as a female sex worker, you should have access and a right to get a condom.
Yes. We're almost coming to a close, of course, for this conversation, but there's also a conversation surrounding flavored and textured condoms, where they say that sometimes it can promote safe sex. Is it true, or is it just a marketing gimmick? Cleo, Naomi, let's start with Naomi.
For me, I am not so sure about that. I would say it is a marketing gimmick for me, yes.
Okay, Cleo?
Biashara. Mambo ya town.
Daktari, from the national level.
So for me, the way, I maybe have a different perspective.
Yes.
If that narrative, if it's flavored or textured, if that's going to encourage you to use the condom, then I'm more for telling whoever is producing, please produce those condoms. You understand? It's like if you want to buy a dress, you can choose to buy a second-hand dress or go really high-end, New York, buy a dress. The fact is you're wearing a dress. So it's all about marketing gimmick, and sometimes it's just the label that you put on the dress, isn't it? But that's what I'm saying. We also need to market our condoms like that. So that's part of the market. As long as the condom is safe and KEBS qualified, isn't it? Then please, let's go ahead and market it as long as they are used. That's what I would say.
We want
as Celestine. We want them to be used. We're not going to lie. We don't lie because we also want quality, isn't it? But there should also be a way of getting customer feedback. So if there's this flavor in the month, how do my customers tell me that the flavor work does not work? So we want to normalize the condom conversation.
Amazing. Final remarks as we close. Tomorrow is Valentine's Day, okay? And it's amazing that International Condom Day comes just a day before that. So your final remarks as we close, Naomi?
So my final remarks today is just to talk about the ICD activity that is happening at Mathare right now.
Okay.
We started with a procession, a road show. We will be having a mini medical camp at Mathare Austin ground. So people can access services ranging from HIV testing services, STI services, and of course access condoms from that venue and from our clinics. Yeah.
Amazing. Claire?
Well, just go back to my main line and what I advocate for. And I always say that consistent, it's Condom Day. So I want to remind people that consistent and correct, not just consistent and correct use of condoms will give you 99% prevention from HIV, from STDs, and of course from unwanted pregnancies. And of course, I cannot forget to say that I'm very passionate about people testing, and the reason I advocate for testing is because testing is taking responsibility of your life. And I'm here to tell people there's so much life after a HIV positive result. And once you go testing, the results, it's either they're negative or positive. Hakuna in between. If you're positive, we are there to take care. We are there to give you counsel. We are there to work with you until you get to undetectable. If your results are negative, you have another chance to continue putting the preventive measures to maintain the same status.
Amazing. Dr. Harry, as we close.
So for us, our national event is happening in Migori County as we speak, but we're also having the called celebrations in other counties around the country. For me, I would just say that tomorrow is Valentine's Day. Please be safe. Please make the right choices for you. Even beyond Valentine's Day, think about your health and your wellness and your safety. Let's normalize the condom conversation. And please, if you need any sort of help, support, I mean, it is available. People can actually go to our website. There's a lot of material information, even for young people, and a lot of linkage with our partners where they can actually get support. So my overarching message is just be safe and stay well. And happy Valentine's Day in advance.
Happy
International
Valentine's.
Condom Day.
Amazing. Now, speaking of Valentine's, here at TV47 in partnership with the Two Rivers Mall, we have a few giveaways for our viewers. So if you want to join in this challenge, just share a photo or video of your love story and tag TV47 across all social media platforms. Use the hashtag #PicturePerfectLove at TV47. There's so much to be won. We have cash awards, movie tickets, luxury perfume from the perfume store, and a ticket to the Valentine's R&B dinner. So don't let this fantastic opportunity pass you by. It started yesterday. Winners are being announced every day. It will end tomorrow. It's never too late to start now. That was Naomi Kahoro, Prevention Coordinator at AHF, that is AIDS Healthcare Foundation, Kenya, Cleopatra Wanjiku, HIV and Sexual and Reproductive Health Rights Advocate, and Dr. Celestine Mugambi, Deputy Director of Preventive and Curative Programs at the NSDCC. That brings us to the end of this conversation and to the end of Morning Cafe. Thank you so much for staying with us all the way from 6 a.m. up until now. Good morning, have a good day, and Fred and I will see you bright and early tomorrow on Valentine's Day. Have a good day.